Welcome, everyone. Let's see who's the first in the chat box to drop a hello. In typical TBI fashion, let us know you are in attendance, and we'll get the party started with Dr. Koppelson and special guests. There we go. Great to see some familiar names and faces. For those who don't know me, hello, I'm Lately Naruse-Knudsen, co-founder and managing director of the Breathe Institute. And we are so excited to have Dr. Koppelson back. He was on last week with AAPMD, sharing some of the latest research that our amazing group of TBI affiliates and Dr. Zaghi produced. So he is on tonight with much more to share about our Breathe Max department, his brilliant M.I.N.D protocol, and the phenomenal team that makes Breathe Max what it is, including our patients and all of you, the community. So with that, I'm going to take a back seat, and I want to introduce you guys to one of the critical members of our operations team, and someone who started out as a patient in Dr. Koppelson's surgical chair before joining our team to lend her support and wisdom to all of our patients. So please join me in welcoming Laura Wilder, and she'll be giving Dr. Koppelson and Sam the glowing introduction they deserve. So welcome, Laura, and welcome all of you.
Thank you, Laylee. Hello, everyone. Thank you for joining us for our first open access webinar to discuss Dr. Koppelson's M.I.N.D procedure for maxillary expansion. As Laylee said, I'm Laura Wilder. I'm Dr. Koppelson's patient care coordinator and operations manager of the Breathe Max department, which is the oral and maxillofacial surgery department at the Breathe Institute, located in Los Angeles. I'll start by sharing a little bit about my jaw surgery experience while people are still trickling in. I see a lot of you are doing so already. Oh, hi, Ray. Yes, please drop us a little note in the chat letting us know where you're from and how you found out about our webinar today. So like I said, this is our first open access webinar. There will be more, so be on the lookout for more announcements. The best way to stay in the loop is through Dr. Koppelson's Instagram, which you can find here. I'll drop a link in the chat right now. Okay, perfect. I'm actually a former patient of Dr. Koppelson's. I had MMA surgery with him back in December of 2019 to correct an airway insufficiency I had called upper airway resistance syndrome. I had a significant tongue tie that was not addressed until I was an adult, and by then my jaw growth had been affected negatively. I didn't have enough room for my airway, and I needed more space in my mouth for my tongue as well. My body started compensating for my insufficiencies, and it caused me a lot of pain and completely drained my energy. I remember my consultation with Dr. Koppelson being so enlightening. I learned so much about my body, and I was really relieved to finally find a healthcare provider who acknowledged everything I'd been experiencing for years and could tell me exactly how to fix it. Dr. Koppelson was not the first jaw surgeon I met with either. I had surgery scheduled with another doctor, but the procedure that he wanted to perform was only going to address my bite issues from my orthodontic relapse. But once Dr. Koppelson helped me understand how MMA surgery could resolve my underlying issues, the choice was so obvious to me. Like, I didn't want to just slap a Band-Aid on my symptoms. I wanted to eliminate them for good. So I canceled my surgery with the other doctor and moved forward with MMA surgery with Dr. Koppelson, which was absolutely the right call. I'm not trying to overstate this, but it was nothing short of life-changing. Before the surgery, I was sleeping so poorly. I had a ton of microarousals throughout the night, and I wasn't hitting REM cycles the way I needed to. I was exhausted all the time, and my anxiety was through the roof. I had poor head posture that caused chronic neck and shoulder pain. There was nothing I could do to resolve it because when I had good posture, my airway was the size of a cocktail straw. And I had developed a significant anterior open bite that affected the way I ate. And Dr. Koppelson fixed all of that for me. I'm so grateful that now I get to be on the other side of this, helping to guide people through some of the same struggles that I've been through. It's really amazing being able to connect with our patients and relate to them in such a personal level to help them understand their treatment options. It's so rewarding to help them navigate through their health journeys and see how vibrant they feel once they've had surgery and found relief from symptoms they've been struggling with for years. One of my favorite parts of my MMA experience was working with our interdisciplinary team. We have a unique approach to patient-centered care here at the Breathe Institute. Our MMA patients are guided through several meditations with our yoga nidra, and they learn some really great relaxation techniques. This was so important for me before surgery to prepare both my body and my mind for the changes that were ahead of me. Dr. Coppelson even let me meditate in the OR, and I was so relaxed that I fell asleep before they even put me under anesthesia. Our patients also receive individualized pain management care from our pharmacist, and we have a great team of myofunctional therapists. They'll guide you through exercises to help you achieve optimal results after surgery, including massage techniques that help reduce swelling. We can even refer you to a nutrition team who's developed a protocol specifically for Dr. Coppelson's patients. We really believe in total body healing to achieve optimal health, and that treatment should be tailored specifically to the needs of each individual. This is how healthcare should be. And with that, I'd like to turn the time over to Dr. Coppelson so he can tell you more about his version of maxillary expansion surgery. It has been massively successful and has truly changed the lives of our patients. Thank you, Dr. Coppelson.
Thank you, Laura. What an introduction. Amazing. And thank you for sharing your story. Thank you to everybody who joined us tonight. I just looked in the chat. We have people from all over the country, even all over the world that have tuned in tonight. And I'm really honored to have you guys here. Let me start sharing my talk and we'll get started. So thank you all for joining. I know it's probably been a long day, for some of you a long night. I see we have people from all over the world. And I'm very excited to talk about one of my biggest passions, which is the treatment of maxillary transverse hypoplasia or maxillary transverse deficiency. It's been one of the big goals of mine, was to advance this surgical field, the techniques that are used to treat this condition. And the results we've been getting through our protocols, through our techniques, have really been one of the defining happy points in my career so far. The procedure we developed here at the Breathe Max department is called M.I.N.D, M-I-N-D. It stands for minimally invasive NasoMaxillary distraction. And as we get more into it, you'll kind of see why each one of those words are there, because they're all integral to the way this surgery is performed and the results you get afterwards. So for those that are not aware of who I am, my name is Kevin Coppelson. I am a board certified and fellowship trained oral and maxillofacial surgeon, practicing right here in Los Angeles. It's where I grew up, did my college and dental school right down the street from here. I did a residency in oral and maxillofacial surgery at the University of Maryland and the R. Adams Cowley Shock Trauma Center in Baltimore. A really good place to get a surgical training, especially if you want to get good at doing trauma. You know, I developed a love for corrective jaw surgery, for skeletal expansion, and for other procedures where we perform distraction osteogenesis on the jaws. So I did a fellowship in advanced maxillofacial surgery where I tuned in on those skills in anticipation for creating the Breathe Max department here at the Breathe Institute in Los Angeles, California. And here at the Breathe Max department, we are focused on three big things. One of them is research. We take huge pride in conducting pioneering research in the areas of airway, sleeping, and breathing. I'll share in a bit one of the new papers we got published in the biggest journal in my field, in the Journal of Oral and Maxillofacial Surgery, that's going to get published actually in the June edition. It's actually available already online, and I'll share a link. I'm also super passionate about surgical innovation, and me and my team here is dedicated to advancing surgical innovation through the development of novel techniques and technologies that improve patient outcomes and quality of life. And that's kind of where the M.I.N.D technique was born, was like, how can we expand the maxilla better for patient outcomes in terms of improvements to their sleeping, their airway, and their breathing, but also in their recovery, right? So we'll get into how our technique differs both in outcome as well as what the recovery period's like. And last, in patient-centered care. So as Laura mentioned, I am a huge believer in interdisciplinary care, working with a team of healthcare providers that are all excellent in what they do, that all contribute in a different way, that'll improve patient outcomes and improve patient satisfaction. And we have developed the first and the most comprehensive patient-centered care when it comes to corrective jaw surgery and maxillomandibular advancement surgery. And we'll talk about that briefly, just like Laura did, talking about her ability to meditate into anesthesia, which is truly a beautiful story and experience that most patients don't have when they're going in with lots of fear, anxiety, and nerves. Talking about research, I am super, super honored to finally get this article published. It's been, years of hard work. This is a big study. We had over 110 patients that participated. Few got excluded due to, artifacts in the CT scans, but we had 90 total subjects that were included. This is a multi-center study with a bunch of TBI affiliates. We had Dr. Pata, Dr. Stewart, Dr. Harry, Dr. Hansen, as well as Dr. Zaghi and I, who worked on this study where we looked at, does head and neck posture affect the airway on a CBCT scan, right? So the answer is obviously yes. Anyone who works in the airway field knows that patients develop forward head postures, craniocervical extension, as a compensatory mechanism for having a restricted airway. We were able to prove something that we all know, which was not in the literature before, but even more importantly, we were able to come up with quantitative measurements. So we came up with a new cephalometric angle called the Nasion-Bayesian to C3. We call it the MBC3 angle, where you can actually detect craniocervical extension and flexion on a CBCT scan, and then also be able to calculate how much airway change you can see with each 5-degree change in someone's NBC3 angle. And if you guys are interested in reading the paper, we were thankfully able to get it open access. If you scan that QR code, it'll take you right to the website where you can read it or even download the PDF to read it later. These are a couple images from the article, but look, this is the same patient, one in natural head posture, one with craniocervical extension. Look at their airway, like quadrupled in size, right? So forward head posture can be a really powerful thing in opening up someone's airway. Look at someone who has craniocervical flexion. So chin down, look at how much their airway can change. And it's going to be crucial if you're a healthcare provider that treats the airway, that treats sleeping, that treats breathing, that you're able to detect this. So you're not getting falsely elevated airway results or falsely diminished airway results when you're examining a CBCT scan, and also to have reliability when examining 2 CBCT scans from different times. So that's where this article is going to be huge to your practice. We use it all the time. And also where I think a lot of you are going to get benefit is using that MBC3 angle as well. So this is the NBC3 angle, again, Nasion-Bayesian to the upper anterior point of C3. And what you'll get is an angular measurement connecting these 3 points. And on average, it should be about 110 degrees for an adult. And each 5-degree change can result in a 25% increase or decrease in someone's airway size. So it's huge. It can have drastic changes to someone's airway, and it's an important consideration when looking at and comparing 2 CBCT scans. We also developed the first published protocol for taking CBCT scans. So if you are in an office where you take CBCT scans looking at the airway, I encourage you to look at the CBCT scan. This is the first CBCT scan protocol that was tested. So we also looked at different, what we called minor variations in posture, for example, using a chin rest, standing versus sitting, and swallowing once versus swallowing twice. And we were able to come up with a protocol that will help you get the best and most accurate CBCT scans possible when looking at a patient's airway. What you want to have is natural head position, horizontal visual access, closed mouth, breathe through the nose, and place the teeth together. Swallow once, then rest your tongue where it naturally goes, and avoid using a bite registration. And if you're going to use a chin rest, make sure you're not having the patient reach. So that's going to be where the art of it comes in. Again, as Laura said, I love interdisciplinary care. We are getting the best results, the best patient satisfaction, the lowest relapse rates, because we are encompassing an interdisciplinary team where everybody is working together in their own specialty and providing different aspects of the care besides just the surgical part, which I take pride in, but making sure that their pain is well controlled without throwing narcotics at them, making sure they have the proper nutrition, the micro and macronutrients and the hydration that you need to heal and grow bone after having a skeletal expansion surgery. Obviously, you know, I do what I do. I use the best technologies, the newest tools to make sure that we get the best results possible, but also working with the mindfulness and meditation counselor and also working with myofunctional therapy adds so much to providing whole body, mind, and body healing that is really not being done anywhere else in the country. And I'm super proud about that. Okay, so now let's get into what everyone tuned in for, which is maxillary expansion. And the maxilla is actually a bone that I think is misidentified a lot. I think we're used to looking in the mouth, we see where the upper teeth are, and we go, that's the upper jawbone. But that's actually not the case. The maxilla is actually the largest bone in your face. And the maxilla actually encompasses a lot more than what we see in the mouth. The actual body, the main part of the maxilla is here. It's called the maxillary body. And off this maxillary body, there's actually 4 different processes. And 3 of them can be easily seen from the front here. You have the alveolar process, which encompasses the bone that houses the roots of the upper teeth, right? You have the zygomatic process and you have the frontal process. And you can see that the frontal process and that maxillary body are going to dictate the lateral bounds of the nasal cavity. So how wide your nasal cavity is going to be. The 4th process you can kind of see from this posterior view, that's the palatine process. And you can see that dictates how wide the floor of the nose is going to be. And obviously the palate is underneath there. So how wide the palate is going to be, which is going to dictate how much space that you have for your tongue. So what happens when the maxilla doesn't grow wide enough? Okay. This is my amazing Photoshop skills. It looks beautiful. And what you can see is it's not just that you get like the crowding and the narrow palate, but what also happens is you get a narrow nasal cavity and narrow nasal floor. So breathing through the nose becomes exceedingly difficult, and patients have a hard time breathing through their nose. They get more airway collapsibility, and we'll talk about that a bit more in a bit. And this slide is kind of talking about traditional techniques. We're going to kind of get into these in some more detail, but after seeing how big the maxillary bone is, you know, the maxillary body with its 4 processes, look at where the cuts are done in traditional surgeries, right? The traditional surgeries are basically only treating the alveolar process of the maxilla. So there has to be a better way. There has to be surgeries, and there are, you know, that's the whole point of this talk, but there has to be surgeries that address the entire bone so you can get the best results possible when it comes to your nasal breathing, your sleeping, your airway, all of that. So I just wanted to highlight, you know, the traditional surgeries, which are going to be the SARPs, the domes, the segmental Lefort 1 osteotomies, where they're treating. They're basically only treating the alveolar process. That's why the airway, the breathing results you get from them are going to be mild to moderate compared to what you can get from a surgery like M.I.N.D. So what would be some of the dental appearances that you may see? And I'm going to open up my chat box just so I can see everyone talking here. So what are some of the traditional dental appearances that you would see in someone that has transverse maxillary hypoplasia or maxillary transverse deficiency, right? You can see it here. It's pretty obvious. You'll often see a constricted looking arch, which will be V-shaped instead of broad and U-shaped. You'll often see a high palatal vault, so it'll be deep instead of broad and flat. The patient may have a crossbite, right? So usually your upper teeth sit wider than your lower teeth by about 2.5 millimeters on each side. We call that a posterior overjet. And if that is not the case, that is called a crossbite. And you can have a crossbite. It can be either unilateral or bilateral. You can see dental crowding, and you'll often also have impacted teeth, obviously wisdom teeth being the most common version of that. You have functional airway effects, right? So if that palatal bone is narrow, right, we talked about the palatine process and the alveolar process, you're going to have an effect on the tongue, and that's going to be a loss of tongue space. And when the tongue doesn't have enough space in your mouth, a lot of bad things can happen. The most common thing is for the tongue to get displaced posteriorly. And when that happens, your oropharyngeal airway gets smaller. So the airway that all the air that has to pass through when you're breathing through your nose or through your mouth has to pass through gets more narrow because your tongue falls back. That's not good. You also have an effect on the nasal cavity, and that is increased nasal airflow resistance, increased nasal obstruction, and increased pharyngeal collapsibility. So we'll talk about that pharyngeal collapsibility in a second, but it makes sense, right? Nasal cavity, nasal flora narrow. These are patients that are often going to have a hard time breathing through their nose. They will mouth breathe either during the day or during the night, and they'll complain of difficulty breathing through their nose, right? They'll also will have poor sleep patterns and sleep results. So if you did a sleep study, these patients will often have UARS, they'll often be snorers, or they're often, at worst cases, have sleep apnea. And the reason being is something called Bernoulli's principle. It's a principle in physics that has to do with narrowing within a tube. So if you have a narrowing within a tube, whether it's from the tongue getting displaced posterior or from your nasal cavity and floor being too narrow, what happens is you go from having a smooth laminar airflow to a turbulent airflow. And that narrowing and that turbulence causes a negative pressure, right? The air is moving fast, high velocity, turbulent, and that creates negative pressure, which sucks down the walls of your airway. Remember, your airway is a soft tissue tube. And if you create increased negative pressure or just a decrease in pressure, that causes airway collapsibility, which is one of the things that contribute to UARS, snoring, and sleep apnea. So, one of the things we accomplish just by widening the upper jaw is the increase in tongue space, widening of your nasal cavity, easier to breathe through your nose, but now your airway is less collapsible. So that's one of the reasons why these patients have amazing responses in the quality of their sleep. All right, there's some orthodontic and periodontal effects as well. If you have a narrow arch, you're going to have less alveolar bone available for the teeth to be straight. So that's why we see crowding. And when you have crowding, the teeth are not sitting perfectly aligned in the bone. So the roots will often be tipped out of the bone. And it takes very little irritation to start getting gum recession, which is permanent. So this is another important thing that we like to treat. We like to increase the volume of bone so that an orthodontist, dentist can straighten the teeth, put them in a more healthy periodontal position so that they're not getting gum recession and losing teeth early in life. There's a cosmetic thing here, which has to do with negative spaces. In dentistry, we call these buccal corridors. But when you have a narrow upper jaw, you'll often see these increased kind of negative spaces in someone's smile. And when you treat that, you can see you can make someone's smile brighter, bigger, whiter. It has a cosmetic component too, because patients will often ask me like, oh my God, you're going to widen my jaw. Like, what is that going to do to my face? And it tends to be super positive. Patients tend to love the way they look. They get a bigger, brighter, wider smile. And it tends to have really, really positive results. So those are some of the things you may see just clinically peeking at someone's mouth. There are radiographic findings as well. There's two major measurements that I do. One of them is the U-Penn CBCT analysis. This is a skeletal measurement, right? So the next one is going to be a dental measurement, which is super helpful. But this is a skeletal measurement. So I'll go to the first molars and I will measure the skeletal width, and I will measure the maxillary skeletal width of the first molars. Exactly where I do it, you can read the paper, but basically at the biggest concavity at the first molars around the furcation, I'm going to measure the skeletal width. I'll do the same thing at the furcation and the mandible, and now I'll have a maxillary skeletal width and a mandibular skeletal width. And if you remember when I spoke earlier, I said your upper teeth should sit about 2.5 millimeters wider on each side than your lower teeth. And so you should have about 5 millimeters wider bone on top than you do on the bottom. So what you want to do is have, in an ideal perfect world, you should have a maxillary skeletal width that's 5 millimeters wider than a mandibular skeletal width. So that's one of the ways that I diagnose maxillary transverse hypoplasia. The other way is to get an intermolar width, okay? And this can be done either clinically, you know, you can use some kind of Bowley gauge. I just do this on the CBCT scan. So I go to the CEJ and I try to measure, you know, palate to palate of the first molar. And you can see here what someone should be, right? And you won't believe how many patients are walking around 32 and below, which is very severe narrow. Adults should be probably 38 to 40 millimeters across, what we call the intermolar width. So, you know, the teeth can sometimes be tipped and things like that, which can kind of skew your intermolar width. So that's why I like to combine my skeletal measurements, my maxillary skeletal width, mandibular skeletal width, with this, you know, when the teeth are acting as a surrogate to your bone width, and it kind of helps paint a picture of what's going on. Obviously, you have to do a really thorough clinical exam, really thorough history, dive into the patient's orthodontic history, how they're breathing, how they're sleeping. And when you combine everything, that's how you kind of figure out which patients you think would be a good candidate and benefit a lot from a surgery like M.I.N.D. So what are the goals of maxillary expansion? There are 3 major goals. Number 1 is to improve nasal airflow. We do this by expanding the nasal cavity and the nasal floor. This will lead to a decrease in nasal obstruction, decrease air resistance, and remember, it's going to help decrease your collapsibility of your airway, which will help symptoms like, or conditions like snoring, UARS, and sleep apnea. We also want to increase tongue space. We do this by expanding the palate, which allows the tongue to sit in a forward and upward direction. And what this also does is it increases tension on the muscles that attach to the palate, like the palatal-glossus and palatal-pharyngeus muscles, which will help with that retropalatal airway and make your airway a little bit less collapsible as well. Last, we want to increase maxillary arch size. And we do this by expanding the volume of alveolar bone, which gives, again, the orthodontist or dentist room to decompensate crowded teeth. All right. So we talked about the traditional surgeries, right? The SARPs, the domes, the segmental Le Fort 1 osteotomies. They are all based off of a Le Fort 1 osteotomy. A Le Fort 1 osteotomy is a cut that is done all the way across from the tuberosity, which is way in the back, above the roots of the teeth, ending right above the floor of the nose. So every expansion you're going to get with a traditional technique is going to be a Le Fort 1 level expansion. You're not expanding the nasal cavity, right? Just the floor. So the airway results, the nasal obstruction relief you get is minimal in these techniques. I obviously used to do a lot of these, so I know how patients used to respond in their breathing and stuff from getting this procedure done. Compared to now, when I'm doing M.I.N.D, it's crazy. With just a few millimeters of expansion, because it's like a 3D expansion, the airway, the breathing results you get are exponential. So let's dive more. We'll look at the segmental Le Fort 1 osteotomy. This is a type of expansion that's done at the time of corrective jaw surgery. So let's say you're getting MMA surgery or some, corrective jaw surgery for a different reason. You can segmentalize the upper jaw. We usually will do it in 3 pieces, and you can get only about 3 millimeters of expansion per cut, right? So in a 3-piece, it's 2 cuts, which means you can get about 6 millimeters of expansion. The benefit of it is that it's all done at one time. There's no turning an expander. You wake up, you're expanded. But the limitations of it are that, again, only about 6 millimeters of stable expansion, and it's the least effective at improving your nasal breathing. SARPs and domes are all based on what we call a 2-piece Le Fort 1 osteotomy. So it's a Le Fort 1 osteotomy with a midline split. So now you have a Le Fort 1 with 2 segments that split down the middle. The big difference between a SARP and a dome is the type of expander used. In a SARP, you're going to use some kind of tooth-borne expander like a Hyrax. So once you make your cuts, you're literally just going to push on the teeth to have the bone segments split apart. All right. In a dome, you're going to use some kind of bone-borne expander, which is better. So if you're going to choose between the two, you want to have some kind of skeletal anchorage. You're going to get a better result. But they're basically the same surgery. It's a two-piece Le-Fort-1 osteotomy. It's the only question is, are you using a tooth-borne expander like a Hyrax, or are you going to use some kind of bone-borne expander? Mind any procedure you see that uses an expander, whether it's a tooth-borne expander or a bone-borne expander, takes advantage of a process in the body called distraction osteogenesis. Okay, has anyone ever heard of this process before? Yes, awesome. So distraction osteogenesis takes advantage of a naturally occurring thing that happens in the body. So let's say you fracture any bone in your body. Let's say you fall and break your arm. Okay. The first thing that's going to happen is you're going to put the two ends of the fracture together and you're going to stabilize it, right? Either with a cast or some kind of surgery. The first thing that forms between those two fracture segments is something called a callus. All right. What we do in distraction osteogenesis is take advantage of some of the properties of a callus, which is that it's stretchy. So what we do is we traumatize the bone. We create a fracture, right? We do an osteotomy. We create a fracture. We wait for the callus to form, and then we stretch the callus. Then we fixate the callus, and then it turns into bone. So that's really all we're doing in any version of this surgery is taking advantage of the callus through a process called distraction osteogenesis. Again, distraction osteogenesis is a 4-phase thing. The surgical phase is, again, where I do an osteotomy, where I create a fracture in the bone. We then go through a latency period, which is about 5 to 7 days waiting for that callus to form. Then we begin the distraction phase, where we stretch, 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 and then you hold it in the consolidation phase, which I like to wait 6 months, okay? All right, so I made a little treatment algorithm to kind of help guide people into what kind of expansion surgeries exist, and depending on your age and what you're into, what may be best for you, okay? So the first thing to think about is how old is the patient? If you're under 15 years old, then your sutures haven't really fused yet. So you can even get away with using a tooth-borne expander, so like a Hyrax, without any surgery, all right? Now, there still are benefits to doing a bone-borne expander in these cases, but textbook, you can get away with just using a traditional rapid palatal expander. If you're over 15, then you have to diagnose. Does the patient just have a dental alveolar issue, or do they truly have a skeletal issue? If it's dental alveolar, then I'm going to do a surgery like SFOT, which is surgically facilitated orthodontic therapy, where we can expand the amount of alveolar bone available to do orthodontics, or the patient can use some kind of orthodontic expander, dental maxillofacial orthopedic remodeling expander. If the patient truly has a skeletal hypoplasia of the entire maxillary bone, again, through what I told you, good history, good clinical exam, good radiographic exam, then two branches of treatment exist. One of them are the traditional techniques that we talked about, the SARPs, the segmental Le-Fort-1 osteotomy, or the dome procedure, or some kind of minimally invasive technique, which all of them use some kind of bone-borne expander. If you're around 18 years old, you can probably get away with just having a MARPI without surgery. Some people will combine a MARPI with corticopuncture, although I would stay away from this. Being an airway-focused oral maxillofacial surgeon, I don't always get patients that have not had treatment yet, right? A lot of my population are people that have had failed treatment or have had bad outcomes from treatment. And corticopuncture, I don't think adds to the predictability of you expanding, and has a lot of complications that can happen, like oronasal fistulas and things like that. So, if you are a provider that's tuning in to get an intake on things that may be beneficial to add to your practice, I don't think corticopuncture is one of them. There's a procedure called EASE. It's developed by Casey Lee, which is great. It's a procedure where he uses a KLS Martin stock expander Like M.I.N.D, it's a minimally invasive technique that provides three-dimensional expansion of the nasomaxillary complex. So it's a procedure I'm very fond of. M.I.N.D is a procedure that's all done transorally. So it's all done through little incisions in the mouth. So, 3 incisions, maybe about ½ inch across. And the surgery is all done through those little ports. And I use a bone-borne expander. And the results I'm getting are amazing. And I'll share a few cases in a bit. So why choose M.I.N.D surgery, right? Because you go from that Lefort 1 level, kind of just alveolar process expansion to what I call nasomaxillary expansion. All right. Nasomaxillary expansion is where you're actually widening the entire maxillary bone. And with it, you're three-dimensionally expanding the nasal cavity, the nasal floor, the palate. You're also growing alveolar bone at the midline, for orthodontic and periodontal purposes. So it treats everything plus more. Like the airway benefits you're going to get from a procedure like M.I.N.D, the improvements in your nasal breathing, the improvements in your sleep are second to none. And that's why this is basically all I offer now. I used to, do dome on some patients. I've done ease in the past as well, but now I only do M.I.N.D. I developed M.I.N.D just because the cuts I wanted to make, I wanted them all to be in the mouth. So here's a case presentation. This is a wonderful human being who is 36-year-old female. She presented with fatigue, with mouth breathing, with bruxism, snoring and sleep apnea, abnormal bite. She has just tension, depression, anxiety, moderate OSA, even after having a prior UPPP. And she was intolerant to CPAP. Okay. So, this is a very common presentation. A lot of patients out in the community, they don't get correctly diagnosed. They're not getting referred to an oral and maxillofacial surgeon early. So, the ENT goes, okay, all I can really do for you is a UPPP, even though that's not what this patient needs. So this is a pretty common thing I'm seeing. I can't tell you how many MMA patients or maxillary expansion patients I'm treating that have had UPPPs that really didn't get much benefit from it. So it takes a really good ENT to know which patients would benefit from it. It definitely has its role, but unfortunately, it's kind of being offered to some people without them being properly diagnosed. So this patient came to me. We diagnosed her. Oh, this is her sleep study. You can see her HI is 26 events per hour. She had a DICE performed by my partner, Dr. Zaghi, who's an ENT, who is a doctor who will offer UPPPs to the patients who will actually benefit from it. So, he doesn't offer it to everybody. He's like, no, you actually would benefit from M.I.N.D or MMA. He's a, excellent ENT doctor. And he performed a DICE on her. What he diagnosed her with is tongue-based obstruction, concentric collapse of the velopharynx. Her O2 nadir was 79%. Her obstruction improved with jaw thrust. She had some CPAP efficacy between 5 and 10 centimeters of water pressure, and positional therapy was mildly effective. So here's some of her CBCT exam results, measurement results. So this is a 2-dimensional measurement. I don't really do this anymore. I do 3-dimensional airway measurements now, but it's still helpful to look at this. So her posterior airway space measured at 6.7 millimeters long. Her intramolar width was 30.6 millimeters. All right. I did the M.I.N.D procedure with her. I used, this is an MSC appliance and CBCT. Look at this. I find this fascinating. Her posterior airway space now measures at 8.4 millimeters. So even though I didn't do MMA, I didn't bring her jaws forward, increasing the space in her tongue. And this is when she still has her appliance in. And, this is pretty long ago. She now actually has the appliance out, and she texted me that night and she goes, Doc, or the next day, she's like, I slept even better last night. So, these patients get amazing results once they're done expanding, even though that appliance is staying in, and then they get this like second boost when we take that appliance out and increase their tongue space a little more. But look, she had an 8.4 millimeter airway was 6.7 before, so almost a 2 millimeter improvement in her posterior airway space length. Her intramolar width went up from 30 to 37. And how is she doing? And guys, I will answer some of these questions at the end if that's okay, just so it kind of flows better, because they're not really related to what I'm talking to right now. But I will talk about, I'll answer all those questions at the end. I promise we'll have time. So post-expansion, improvement in her nasal breathing. She dreamt for the first time in years. She slept through the night, woke up feeling refreshed, and her biggest issue was actually insomnia, and that went away. What were the structural changes that we achieved? Decreased nasal obstruction, improvement in airflow turbulence. Again, we tighten the muscles around the palate glossus, palatal pharyngeus muscles. More tongue space, less airway collapsibility and obstruction, right? One movement, but because you're doing it in the most efficient way possible, you're getting three-dimensional expansion of the entire nasomaxillary complex. You're getting three-dimensional expansion of the nasal cavity, the nasal floor, the palate. Even just by getting someone, 5, 6, 7 millimeters wider, you are improving their sleep tremendously, their nasal breathing tremendously, just with this one direction, right? So it's pretty cool stuff. Next case is an amazing human being. I don't know if he's still 31, but we'll find out in a second. But at the time was a 31-year-old male. He presented with crossbite, TMD, mouth breathing during the night, difficulty falling asleep, unrefreshing sleep, and an abnormal bite. All right, so we did the M.I.N.D procedure for him. You can see how wide the nasal cavity and nasal floor got. Again, widened palate. And that all fills in, right? Look, he still has his midline suture, which is super important when you're looking at things like cranial strain, right? So the midline suture is intact. The bone will be able to flex the way it needs to. But what we've done is widen the nasal cavity, widen the nasal floor, right? Already super handsome guy, right? Maybe he developed to where he was supposed to develop to if his bone didn't have that transverse deficiency. And he looks like a better version of himself. Already super handsome. Now he has to push the girls off. We'll find out in a bit. But wider palate, better bite, more functional bite. And he's actually a special guest. He is a super busy guy. He's an amazing physical therapist here in the Los Angeles area, and he's very gracious to be here with us tonight. I wanted a patient to give you their perspective on what this procedure can do for your breathing and sleeping. And without further ado, let me stop sharing so we can see you a little bigger. We have Sam here who's joining us. Sam, hello, welcome.
Hello.
So
yeah.
So Sam, you were an early patient in the M.I.N.D. You wanted the minimally invasive approach to what I was doing. And why don't you tell us kind of what you've experienced before, and then since undergoing the operation, kind of how life has been, breathing, sleeping, function, all that stuff.
Yeah, happy to. I related to Laura's story because, it was kind of serendipitous, actually. What prompted me to consult an orthodontist was that I noticed my crossbite had been getting worse in the past maybe 5 years. And I started noticing some chipping on my lower teeth and upper teeth, actually. It felt like all of my contact, all of my bite force was coming through my upper teeth. But sort of concurrently, I had been a lifelong, lifelong sufferer of insomnia, lifelong mouth breather at night. Even as a kid, like I just never had a good relationship with sleep. I never felt rested unless I somehow, was able to sleep for very long periods of time. But it was just not a pleasant, sleep was never easy for me. And also I didn't know growing up that it's not optimal or not normal to, breathe through your mouth when you're sleeping. So, but in my 20s, as a young professional and my insomnia started to be more problematic. And I also, I'm a physical therapist. I had a pretty intense athletic background. I did ballet when I was younger, competitive weightlifting. And so I started getting a lot of injuries in my 20s, despite having a decent knowledge of how the human body works with those sort of things. It was because I was never really getting sufficient rest. And I started to realize that that was the underlying issue. And so when I consulted a couple orthodontists about just about the bite, while separately on my own, I was learning about the detrimental effects of mouth breathing on your sleep. It was kind of just confirming my experience. And I was doing breath work and all of these things, mouth taping to try to optimize my nasal breathing. But it, as you could imagine, can only get you so far because the bony structure of my sinuses was the limiting factor. So I saw an orthodontist, a couple orthodontists. They both said, okay, the narrowing of your upper jaw and your crossbite is significant enough that you really the only way to fix this would be through surgery. And I, like Laura, also saw another oral surgeon, two oral surgeons, both of whom recommended was going to have to be 2 jaw surgeries. I don't know the details on what those procedures were, but it was a 2-step process, but it sounded, incredibly invasive. And so I was not enthused about that. And then but because I had been just independently learning about, ways to improve nasal breathing, and I saw that there's a procedure that does widen your upper jaw. And sometimes people get it just for the breathing component. And that obviously caught my eye because I was like, all right, well, this could maybe be a 2 birds, 1 stone sort of thing. And I saw Dr. Koppelson, and he kind of confirmed that for me, that it would be a significantly less invasive surgical route to improve the space of the upper jaw, which would then allow for, realignment or orthodontically to fix the crossbite, and then also improve the airway for the breathing and the sleep quality. And it had become very clear that my sleep quality was unsustainable. I was really struggling, to just function with a busy schedule and being very active and just never resting, really. And so I went forward with the surgery, and noticed breathing improvement. Way sooner than I thought. When we had, I think, 2 millimeters, I started noticing the breathing improvement, and that's even with, the post-operative swelling and everything. And so then I think we went to 6 millimeters total. And so by the end of that, it was it really could not have been more significant. The ease of breathing and the sleep quality, even with the hardware in my mouth and everything, the sleep quality was improving very quickly, which was a huge relief because I had noticed also, like Laura said, my, preoperatively, I had made the connection that my lack of sleep or my lack of quality sleep was having physical effects because I was getting injuries and things like that. And also just anxiety and stress. And so I can't really overstate what it was like to finally feel like I achieved a restful night's sleep and to wake up in the morning not feeling like garbage, which I had just been used to my entire life. And so, despite it's obviously, there's some discomfort. It's a jaw surgery. There's metal in your mouth, all this stuff. But, I could tell Dr. Koppelson did a really great job of explaining the procedure beforehand. And it very much lined up with my experience. I mean, the incision really, it felt very small. So it's like, all things considered, it, even though there's some discomfort, it really didn't feel very invasive. It was mostly just, pressure from the device. And yeah, and then, I'm still undergoing the realignment of just getting the teeth back, in where they need to be. Mostly just like for cosmetic purposes at this point. But the breathing has been, the breathing improvements and the related sleep improvements have been life-changing. And yeah, and so it's just, it really, I'm very grateful for that.
Awesome, Sam. Thank you so much for sharing. I mean, all day I can be a doctor who's like, the surgery is good, the surgery is good, it's important, you should get it, you should get it. But I think hearing it from a patient's perspective, because I think a lot of people out there can relate to some of the symptoms you were experiencing, some of the way you were feeling about your sleep and your breathing and your bite and things like that. It's very, very common. So I really appreciate you for sharing your experience and being so eloquent in the way you kind of described everything. So thank you so much. I really appreciate you.
Thank you.
Yeah. So let's do a couple more slides. So that's my special guest, guys. I made a special slide for Sam. He's my special guest. Really, really honored to have him be here to be able to share a patient's perspective. So the M.I.N.D technique, right? So this is a little summary of what to know. Again, small incisions. There's about 3 of them, this big, half an inch or so. Probably even way smaller now than when I did Sam's surgery. I'm always tweaking and tweaking, which means less pain, less swelling. I mean, I can't tell you how often I have patients that tell me, oh, I thought I was going to be in a lot of pain. I took pain medication, but I realized I didn't really need it. It was manageable with just over-the-counter stuff. Very minimal to no pain or swelling afterwards. Obviously, that varies patient to patient, but in general, it's very little pain or swelling. You get true nasomaxillary expansion for the best airway results possible. And a lot of people want to know where is it done? Is it like in a hospital? Is it, in office? The truth is we do it one of 3 ways. Okay, so 2 of the ways are right here at the Breathe Institute. One of them is just under local anesthesia, so fully awake. I do the operation. I numb you up, obviously, do the operation. We do it in office with an IV sedation. So we get you nice and relaxed right here, numb you up and do it while you're super relaxed. And then the other way would be under general anesthesia, either at a hospital or at a surgery center where you're, fully out, anesthesiologist there. So it's really one of those 3 ways, just depending on what your needs are, right? Like what level of anxiety do you have at baseline and things like that. So if you guys want to get in touch, if you are a patient, prospective patient, or a healthcare provider that thinks you have a patient that could benefit from the surgery, please reach out to us. We would love to collaborate on these cases. We would love to take care of you if you're a patient that feels like you are suffering from some of these issues that this procedure could treat. You can reach us by phone. That's our number there. Probably email is the best way, Dr. Koppelson at thebreatheinstitute.com. Again, we're located right here in Los Angeles, in the heart of Westwood, right by UCLA. So now I will start doing the questions where was I? All right. So is there an age limit for M.I.N.D? Okay. The answer is no. I've done this up to the 60s. And really, I don't have a cutoff point at the 60s. I just haven't been seeing 70-year-olds walk through my door too much. Really, it depends on, how healthy is your periodontium? How healthy is your heart, right? Do you want to put someone through even this, even though it's minimally invasive, if, they're just, not in a great overall health state? So it's really a case-by-case basis. If you're a, good functioning 80-year-old, 70-year-old, and you have this issue, it's like one of the only things you have going on, then of course I would treat it, especially because it's so minimally invasive. We're doing it in the office. We're not even taking everybody to the hospital or, a surgery center, it's not as big of a deal as some of the traditional techniques where they're big operations, lots of risk of bleeding, and it's being done under general anesthesia. Can my procedure be covered by insurance? Yeah, really depends on your insurance policy. I'd say it's not as covered as often as like an MMA procedure would be, but we have a pretty good rate. I think we're batting at around 50%. So it really depends on your insurance. You also ask, does this require a patient to fail or be intolerant to CPAP? Not necessarily. That's much more common in MMA surgery, much less common in a maxillary expansion surgery. What options are available for mandibular expansion to match the maxilla? That's a great question, right? So what we're doing is orthopedically widening the upper jaw, right? We're skeletally widening the bone apart, and the teeth follow the bones as they widen. And the question becomes like, what do you do for the lower arch for the teeth to match? The truth is 99% of the time, we are going to orthodontically expand the lower arch to match the orthopedically expanded upper arch, okay? Most patients have enough alveolar bone for the orthodontist to widen that lower arch so that when we orthopedically widen, everything matches up. There are some patients that don't, and I'm doing a procedure that I talked about briefly in that slide where I was going through the algorithm of treating maxillary transverse hypoplasia. And that's a procedure called SFOT, or surgically facilitated orthodontic therapy, where I can actually add bone. We do some other stuff, but we're also adding bone to the mandible so the orthodontist has more bone to widen the teeth of the lower arch so that it'll match. And in really extreme cases, we're going to do some kind of mandibular distraction, all right? But that's pretty rare. And sometimes at the time of MMA surgery, I can actually widen the mandibular arch as well. So, 98% of the time or so, we're able to do it orthodontically, either with or without SFOT. And about 2% of the time, I'll either widen the mandible at the time of MMA surgery, or we'll do a separate procedure where we do transverse distraction of actually the mandible. But it tends to be pretty painful. It's not as predictable and pretty as getting maxillary transverse expansion done. We got an age question again. I feel like I answered that. And as for someone who has had septoplasty and turbinate reduction, is empty nose syndrome a potential? That's a great question. I've looked this up. There's no documented cases of maxillary expansion causing empty nose syndrome that I could find in the literature. That doesn't mean it can happen, because as you widen, especially with a procedure like M.I.N.D or ease, and you're getting 3D expansion of the nasal cavity, that becomes a concern, all right? Empty nose syndrome is obviously something that is, we want to prevent at all costs. The truth is, just looking at it from a physiological perspective, one of the beauties of having a distractor is that the distractor can go two ways. So if you start developing empty nose syndrome, once you reach a certain expansion, theoretically, we can just undo the expansion. Again, the callus is just soft tissue. It's not like as you expand, you develop hard bone in the middle and you can't go back anymore, right? So if you start developing that due to the physiology of the way air moves through your nose, theoretically, we can undo it. Now, I haven't had a patient develop it. I could not find it in the literature, but that's something I've thought about. And that was my solution to it, is that, we can just undo some of the turns and hopefully reverse the empty nose syndrome. Does the M.I.N.D procedure increase the width of the alar base? No. So unlike a Lefort 1 osteotomy, you're not going to get an increase in the alar base from this procedure. The incision is about this big. We're not messing with the transverse nasalis muscles. So you will not get any alar base widening from that. So that's a very important question. Cosmetically, you will not get a wider external nose. The widening is on the skeleton on the inside. That's it. How long does the procedure take? Hour and a half, 2 hours, something like that. Oh, Laura already answered that. There you go. Emma asked like the whole timeline. Okay, so we do the procedure, right? We wait about 5 to 7 days for that callus to form. Then we start turning, right? Everyone's different on how much turning they're going to have. So let's say it's about a month of turning the appliance until you're done turning. At that point, we wait about 6 weeks to start orthodontics, 6 months to remove the appliance. So, total about like 6 months, but you'll still have ortho maybe for another 6 months after that. Ortho is different for everybody. It can take a really long time. But from a surgical perspective, 6 months before we do the procedure and we remove the entire appliance. And then braces may take another 6 months or so because you're doing braces while the appliance is there. So it's not like we wait 6 months to do ortho, but it may be another 6 months or so. Yes. Thank you, Sam. Thank you, Sam. We have so many people in the chat that are thanking you for sharing your story. Thank you, Sam, again. Sam was actually in Invisalign for most of the time. I think he's just doing a little refinement work. So he has a few brackets up front, but he was in Invisalign for most of it. Thank you, Sam. Thank you, Sam. Amazing job, Sam. Okay, we have a question. Can M.I.N.D work on someone with less than 30 millimeters? I'm guessing you're talking about intermolar width, or is MMA a better option? No, if your intermolar width is less than 30, then M.I.N.D is way better. Again, if you're doing MMA and you're going to try to widen the jaw, you're going to be doing a segmental Le Fort 1 osteotomy. And that's the least effective at improving your breathing. You can only get 6 millimeters of stable expansion. So I would definitely stage, I'm doing a lot of that now, Maria, where I'm actually doing M.I.N.D first. I'm treating the transverse, getting that 3D expansion that you would not get in an MMA procedure, and then doing the MMA later if they still need it. So great question. Definitely, if someone has a less than 30 millimeter intermolar width, M.I.N.D for sure, and then reassess for MMA after if they need it. How do you decide M.I.N.D versus MMA? No, so it's not a substitute for MMA. M.I.N.D treats maxillary transverse hypoplasia. So it's like, did the upper jaw not grow wide enough? MMA generally is a treatment that treats forward growth and orientational issues. So imagine like your upper jaw and lower jaw didn't grow far forward enough. And then let's say you have a steep occlusal plane angle, right? So you can do counterclockwise rotation, you can fix midlines, you can fix cants, and then you can bring the jaws forward and open up the airways. So with M.I.N.D, you're really not treating that. You do get a little bit of anterior movement from doing M.I.N.D, but it's only about 1 millimeter or 2. But if someone needs a real significant anterior posterior movement, then they're going to need MMA. The question becomes, there are patients that are narrow, plus they haven't grown far forward. And it's like, how do you best treat that? And in those patients, I like to do M.I.N.D first, because we are 3-dimensionally expanding the upper jaw, and then doing the MMA at a later date. Canadian patients, I don't know, Jason, I think you have to talk to Trudeau. I've treated a few Canadian patients, and I think they had to pay out of pocket for everything because you guys have the government healthcare, and I know it's almost impossible to get these procedures done. But honestly, like the M.I.N.D procedure, I think is pretty affordable given the global scale of things, and especially if you get it done in office and you're not, as a Canadian, you're not having to pay for a hospitalization and things like that. It can be a lot cheaper. Do I accept international procedure patients? Absolutely. Is there I'm not going to perform surgery on a fake skull today, Jason, but maybe in the future. That's a good idea. I'm using usually some kind of MARPI. Lately I've been using a lot of custom MARPIs that I wasn't using before, which I like a little bit better. But you can see like the last 2 patients I used for the 2 case examples, including Sam's, I used an MSC. But I'm trying to tweak things. I'm using a lot of custom MARPIs now. How do you coordinate with out-of-state orthos? Great question. I have an amazing team. We spend a lot of time making sure that there's no lapse in communication. I spend a lot of time talking to the orthodontists. So it's just a lot of hard work and just caring, to be perfectly frank. Probably 75% of my patients come from out of town. So we're just very well versed at having out of town people. And how long would the patient stay in LA? I've had patients stay for 5 days. That works pretty good. I think a week is ideal. I had a patient that left the day after without telling me. So I wasn't super pumped about that, but she's doing fine. But I'd want to see her at a week. So she left and came back a week later. In an ideal world, let's say 5 to 7 days, I expect for you to stay. Can M.I.N.D help in mid-face advancement? So you will get a natural about 1 to 2 millimeter advancement as you bump into the plates, they'll come forward. You can wear a reverse pull face mask. So you can attach hooks to the appliance and then have a reverse pull face mask. In adults, the literature shows you can get about 2 to 3 millimeters of mid-face advancement with that. I've had a couple patients try, but they weren't very compliant. I have another patient that's going to be trying again, so hopefully she'll be more compliant and I can talk more of it. All I can talk about is the literature, which says that with the reversible face mask, which we can, make hooks for, you can get about 2-3 millimeters of advancement. So I use about an expander that has 4 screws or 6 screws. It really depends on the quality of bone, how much bone someone has. So that's kind of the art of doing a lot of these. You kind of know what works, what doesn't. And then what with a segmental Lefort 2 or 3 pieces, what is the maximum amount of transverse you can get, right? So with a 2-piece Lefort, you can get 3 millimeters. With a 3-piece Lefort, you can get 6 millimeters. Are there any potential complications? No, my surgery has 0 complications. Yes, of course. Any surgery, any irreversible thing you do to the human body can have complications. It's very low, especially in a minimally invasive operation, much less than getting a Lefort 1 osteotomy. Anytime you're cutting the root between the teeth, there's always a chance of having injury to roots of teeth. Even just from the expansion, the roots can get concussed and traumatized. It can lead to things very low, obviously infections, 1 or 2%. The good thing is like the risk of bleeding and all that is like basically nil. And the swelling is minimal and the pain is minimal. So yes, complication risk exists. Anyone who tells you there's a surgery that exists without complications, I'd say find a new doctor. If your patient is a clencher, and what do you recommend? You just kind of have to push through it. If they can, the truth is most patients that clench, once you start changing their bite, right, as they expand, they tend to get out of those neuromuscular ingrams that cause them to clench because their bite is changing and their body just kind of stops clenching most of the time, although some patients will start to clench harder. So it's just something we have to push through. Actually, on a couple of patients, I've done Botox just to help lessen the force in those cases. What about palatal tori? When are they a problem? When do they need to be removed? Do they remodel with expansion after? Great question. I think I know why you're asking this. So the tori, it really depends how big they are, okay? If they're super big, we have to remove them either beforehand or during the procedure. If they're not too big, we can sometimes get away with actually using them as anchorage. So you can actually get a little bit better anchorage with the screws. So it really depends on how big they are, where they're located. They can sometimes be beneficial. They can sometimes be something that has to be dealt with either before or during. Do they remodel with expansion? Probably not. What time frame do you want between M.I.N.D and MMA if both are needed? I'd say minimum of 6 months, ideally 9 months to a year. What are the points of fixation after osteotomy as maxilla will be floating? Well, again, M.I.N.D, unlike a 2-piece Lefort, there's always contact points, right? So you're going to be hinging off of the zygomatical frontal sutures, right? So it's not really like floating around wobbly, right? So unlike a 2-piece Lefort where it would be a little more wobbly, it's not as wobbly. It's more of a hinge on the zygomatical frontal suture. Our fracture potential, I would say having fractures, let's say unfavorable fractures, is a lot more common in someone that is not having surgical assisting. So if you're doing like cortical puncture and cranking on an expander and hoping that it splits, that's where you start having those weird fractures. Luckily, I haven't had that happen with my surgery. But I think it's much more common in those non-surgical cases. I don't work with the osteopath, but I love osteopathic work. It's super important and I learn a lot. I get to lecture to osteopaths a lot and I'm always learning so much from them. So I would love to work more with osteopaths. I think I missed a question. Is there a time frame one should wait after giving birth or breastfeeding? I don't think so. The TADs that are the only thing that are in your body are basically like 95% titanium, 5% nickel. So as long as you don't have a nickel allergy, I don't think it should be a big deal. No, Have you ever heard of? Yes. So, yes, big fan of osteopaths, bodywork professionals, and naturopaths. So if you guys are in the crowd, I really do love talking and learning from you guys. I hope you find what I'm talking about interesting as well. So we have ran a little bit over, but I had a lot of fun talking to everybody, answering all your questions. Thank you for being so engaging in the chat box. I hope I answered everyone's questions efficiently. And thank you again from the bottom of my heart. So one more slide. Thank you. And if you guys want to ever reach out, you can find my email, drkoppelson@thebreatheinstitute.com. My Instagram is Dr. Koppelson, and my Facebook, which I really don't go on much anymore, is Dr. Koppelson.
Love the commentary and all the questions, guys. It's so helpful, not only in terms of the Institute as a whole, knowing what additional speakers, case studies, research to bring out for all of you, but just a huge thank you also to Laura and Sam for coming on and sharing patients' perspective and experience. We thought that would be so incredibly helpful. And Dr. Koppelson has now operated on patients from their 20s, 30s, 40s, 50s, 60s. So it's just phenomenal. And we're going to continue to bring more and more resources to all of you. We welcome consultations, both virtual and in person. And Sam, we'd love to have you back always, because the role of what this does, not only to the airway, but the body and our overall mindfulness and presence is so beautiful. And Laura, you articulate that beautifully. So let's just give Dr. Koppelson and gang a huge round of applause. And thank you to all of you who just continue learning day in and day out, and for the work that you all do in your community. So enjoy your Thursday evening. Stay in touch. More to come from the Breathe Max team.
Thank you, everybody.
Bye.
Have a great evening.